Disclaimer. This lecture covers topics such as suicide and self-harm, including realistic case studies based on clinical and research-based presentations. The purpose of this discussion is to educate and raise awareness, not to glorify or sensationalize suicide. National Suicide Prevention Lifeline, US. 988 Crisis Text Line. Text HOME to 741741 Veterans Crisis Line, 988, then press 1. If at any point you need to step away, take a break, or talk to someone, please do so. Major depressive disorder, bipolar disorder, and grief. Introduction: Understanding mood disorders. Mood disorders are among the most prevalent mental health conditions, affecting people of all ages and backgrounds. They don't just change how a person feels, they impact their energy levels, sleep, appetite, relationships, and ability to function in daily life. People with mood disorders often struggle to recognize what's happening to them. They may blame themselves, think they're just lazy or not trying hard enough, or believe that things will never get better. Mood disorders are not personal failings. They are complex conditions shaped by biological, psychological, and social factors. Today, we will explore 3 major areas of mood disorders through the stories of real people, not statistics, but individuals whose lives have been deeply impacted by these conditions. Major depressive disorder. When sadness turns into something much deeper and more paralyzing. Bipolar disorder, the extreme highs of mania and the devastating crashes of depression. Grief versus depression. How normal mourning can sometimes turn into something that requires professional intervention. Case Study 1. Major Depressive Disorder, The Weight of Nothingness. Narrative Story. The case of John W. John W. was never the loudest guy in the room, but he was passionate, driven, and dependable. As a sophomore biology major, he worked hard in his classes, played intramural soccer, and loved nothing more than late-night study sessions at the library with his friends. Then, slowly, something changed. At first, it was subtle. John started sleeping in a little later, brushing off invitations to hang out and skipping soccer practice. His friends assumed he was just busy with school. Then things got worse. He stopped showing up to class altogether. He slept for 14 hours a day, yet still felt exhausted. When his roommate joked about his hibernation mode, John forced a smile but felt nothing inside. Food lost its taste. He'd stare at his plate for hours, take a few bites, and push it away. He lost 10 pounds in a month, but he barely noticed. His mind turned against him. He couldn't focus on lectures, and his once impeccable study habits vanished. His grades plummeted, and with every failed exam, a little more of him disappeared. One night, his best friend confronted him. "Dude, are you okay? You haven't been yourself lately." John looked at him blankly. "I don't know, I don't feel anything." He wasn't sad, he wasn't angry, he wasn't even anxious. He felt like a hollow shell, like the person he used to be had faded away. Then the thoughts started creeping in. It wouldn't matter if I was here or not. He didn't have a plan, he wasn't thinking about doing anything. But the idea sat there, quiet but persistent, like a shadow he couldn't shake. DSM-5 diagnosis for major depressive disorder, MDD. To be diagnosed with MDD, a person must experience at least 5 of the following symptoms for at least 2 weeks, with at least one being depressed mood or loss of interest. Depressed mood most of the day, nearly every day. Loss of interest or pleasure in almost all activities. Significant weight loss gain or changes in appetite. Insomnia or hypersomnia, sleep disturbances. Fatigue or loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating or making decisions, recurrent thoughts of death or suicide. John meets at least 6 criteria, meaning he is clinically depressed, not just experiencing temporary sadness. Biopsychosocial model analysis of John W. Biological factors, genetic predisposition. His mother had depression, increasing his risk. Neurotransmitter imbalances. Low serotonin and dopamine levels contribute to his exhaustion and numbness. HPA axis dysfunction. Chronic stress leads to excess cortisol, worsening depression. Psychological factors, cognitive distortions. John thinks I'm a failure, reinforcing his negative emotions. Rumination, constantly replaying mistakes and regrets. Low self-efficacy, he believes nothing he does will make a difference. Social factors, loss of support. He has been withdrawing from friends and teammates. Recent breakup, a painful emotional event that may have triggered the depression. Financial stress. He's working extra hours to afford tuition, increasing his exhaustion. Case Study 2. Bipolar Disorder, The Rise and Fall of Mania. The case of Sarah P. Sarah P. had always been ambitious. A self-made graphic designer, she thrived on creativity. She could work for days without stopping, her mind overflowing with ideas. 3 weeks ago, Sarah felt unstoppable. She stayed up for 48 hours straight designing 5 new websites. She barely ate. She didn't need sleep. Her ideas flowed like water, her fingers racing across the keyboard. Her confidence soared. She spent $5,000 impulsively, convinced that these investments would make her rich. She booked a flight to Italy because she had a feeling she was meant to go there. Then, just as suddenly, the crash came. She couldn't get out of bed. Her body felt like lead. The creative energy that had fueled her just days ago was gone. Her inbox overflowed with unread emails, but she couldn't bring herself to care. When a friend checked in, Sarah whispered, "I don't even recognize myself anymore." DSM-5 diagnosis for bipolar I disorder. Bipolar I requires at least one full manic episode lasting 1 week or more. Major depressive episodes are common but not required for diagnosis. Manic episodes include inflated self-esteem/grandiosity, decreased need for sleep, rapid speech, flight of ideas, risky behaviors, spending sprees, impulsive travel. Sarah clearly meets bipolar I criteria, as her mania led to reckless behavior and was followed by a depressive crash. Biopsychosocial model analysis of Sarah P. Biological factors, family history. Her grandmother had bipolar I. Dopamine imbalances. Excess dopamine causes mania. Depletion leads to depression. Psychological factors. Impulsivity. She makes reckless financial decisions. Emotional dysregulation. She cycles between extreme highs and lows. Social factors. Financial instability. Spent $5,000 impulsively. Strained relationships. Friends struggle to keep up with her erratic behavior. Key takeaways. Depression is not just sadness, it is a biological disorder that requires treatment. Bipolar disorder is not just mood swings, it involves extreme shifts that impact life stability. Grief and depression are different. Long-term grief may turn into a disorder. Mood disorders are treatable, but only if they are recognized and taken seriously. Understanding suicide. Suicide is one of the most misunderstood and stigmatized issues in mental health. It is often portrayed as a singular decision, but in reality, suicide risk is shaped by multiple factors: biological, psychological, and social. Common myths versus facts about suicide. Myth: people who talk about suicide are just seeking attention. Fact: most people who attempt or die by suicide gave warning signs beforehand. Myth: suicide happens suddenly without warning. Fact: while some suicides are impulsive, many occur after weeks or months of distress. Myth: only people with diagnosed mental illnesses die by suicide. Fact: while mental illness increases risk, life stresses like job loss, financial struggles, or relationship breakdowns can trigger suicide in someone without a diagnosis. Myth: talking about suicide makes people more likely to attempt it. Fact: open conversations reduce risk by allowing people to seek help. Suicide is not just about depression. It can be linked to trauma, chronic illness, economic hardship, addiction, and impulsivity. Today, we will explore 3 case studies to understand how suicide risk develops and how we can intervene. James K., a veteran struggling with PTSD and isolation. Maria R., a college student burdened by shame and cultural stigma. Ethan C., a high-achieving teenager battling perfectionism and hidden pain. Case Study 1. The Veteran Who Felt Left Behind. The case of James K. James K. was a 35-year-old Marine Corps veteran. He had served 3 combat tours in Afghanistan, returning home with a chest full of medals, but an invisible burden he couldn't shake. For years, James had been the one people relied on, the leader, the protector, the strong one. But since coming home, he had felt disconnected from civilian life. The skills that kept him alive in combat, hyper-awareness, vigilance, emotional control, didn't translate to life back home. The nightmares started first, then the flashbacks. Loud noises made him jump out of his skin. Crowded places felt like a battlefield. He avoided them entirely, spending more and more time alone. James started drinking heavily, telling himself it helped him sleep. But the more he drank, the more he pulled away from his family and friends. His marriage was falling apart. His wife begged him to see a therapist, but James refused. Real men don't talk about feelings. One night, his wife found his military medals in a box by the door. Confused, she asked him why he was giving them away. "I won't need them anymore," he said. She panicked. This was a major warning sign. But when she confronted him, he shrugged it off. "I'm fine." James didn't think of himself as depressed. He wasn't sad, but he felt empty, broken, like a burden to everyone around him. That night, as he sat alone with a bottle of whiskey, he felt like there was no way forward. DSM-5 suicide risk factors in James K.'s case. Psychological risk factors, PTSD, flashbacks, nightmares, emotional numbness. Substance use disorder, alcohol increases impulsivity and risk. Cognitive distortions, I'm a burden, my family would be better off without me. Biological risk factors, trauma rewires the brain. Veterans with PTSD often have an overactive amygdala, fear center, and low serotonin levels, increasing impulsivity. Genetic predisposition. Suicide risk is higher in those with a family history. Social risk factors. Loss of identity. Transitioning from military to civilian life is a major challenge. Masculinity stigma. Fear of being seen as weak prevents help seeking. Access to lethal means. Veterans often have access to firearms, increasing risk. The case of Maria R. Maria R. had always been the perfect daughter. She was the first in her family to attend college. Her parents had sacrificed so much to give her this chance. She worked 2 jobs while maintaining a 4.0 GPA. She never let anyone down, until she did. Maria had always been careful, but one mistake changed everything. She got pregnant. Her family was deeply religious. If they found out, she was terrified they would disown her. She imagined the disappointment in her mother's eyes, the shame in her father's voice. So she kept it a secret. For weeks, Maria stopped sleeping. She lost weight, but not from morning sickness. She just couldn't eat. She spent hours alone in her dorm, staring at the ceiling, trying to figure out how to fix this. One day, she wrote a long letter to her parents, apologizing for being a failure. Her roommate found it just in time. Biopsychosocial model analysis of Maria R. Psychological factors. Perfectionism, feels she must meet unrealistic expectations. Hopelessness, believes there is no way out. Shame-based thinking, I have dishonored my family. Biological factors, chronic stress raises cortisol levels, increasing suicidal ideation. Sleep deprivation worsens emotional regulation. Social factors, cultural stigma around pregnancy, fear of rejection. Lack of support system, no one to confide in.
Suicide is complex and multifaceted. Recognizing warning signs can save lives. Early intervention, social support, and therapy are key. Now that we've explored the complexity of suicide and the factors that contribute to it, the next step is understanding how professionals assess risk and intervene. Suicide is preventable, but effective prevention requires recognizing warning signs and risk factors, conducting suicide risk assessments, understanding crisis intervention strategies, and applying evidence-based treatment approaches. Today, we will go through 3 case studies showing different crisis situations, followed by an in-depth look at suicide risk assessment and intervention models used in clinical practice.
Case Study 1, The Immediate Crisis. Jason, a 17-year-old in active distress. Narrative story. The case of Jason C. Jason C. was a high school senior with a bright future, or at least that's what everyone thought. He was president of his class, a varsity soccer player, and had already been accepted into his dream college. But behind the perfect student image, Jason was struggling. His parents had high expectations. Anything less than an A was unacceptable. The pressure to succeed felt like a weight crushing him. One afternoon, he received a college rejection letter from a school he had secretly hoped to attend. Something inside him snapped. That night, Jason sent a text to his best friend. "I'm sorry, I can't do this anymore." His friend immediately called 911, and paramedics found Jason alone in his room, holding a bottle of pills. At the hospital, he refused to speak. When asked directly if he had planned to die, he nodded silently. Crisis assessment: how professionals evaluate Jason's risk. Mental health professionals use structured suicide risk assessments to determine the severity of risk and the most appropriate intervention. The Columbia Suicide Severity Rating Scale, CSSRS, is a widely used tool that assesses suicidal ideation, suicidal intent, and suicidal behaviors. Suicidal ideation, thoughts about suicide. How often does the person think about dying? Do they have specific thoughts about how they would do it? Suicidal intent, motivation and seriousness. Have they made preparations, like writing goodbye notes or giving away belongings? Do they believe death is the only way out? Suicidal behaviors, past attempts or rehearsals. Have they attempted suicide before? Have they taken any steps toward an attempt? Assessing Jason's risk level, risk factor, Jason's case. Frequent suicidal thoughts? Yes. Jason has been struggling silently for months. Specific plan? Yes. He attempted to overdose. Sense of hopelessness? Yes. He believes he can't live up to expectations. Lack of protective factors? Yes. He hasn't told anyone about his struggles. Jason is classified as high risk, meaning he needs immediate crisis intervention. Crisis intervention for high-risk individuals includes emergency psychiatric hospitalization for safety and stabilization, no suicide contract versus safety planning, family involvement and psychoeducation, and follow-up care like therapy, medication, and long-term coping strategies. Case Study 2, The Hidden Crisis, LaToya, the college student who seems fine. Narrative story: the case of LaToya B. LaToya B. was the person everyone turned to for advice. She was a natural caretaker, always putting others first. Her friends admired her for being strong, independent, and always in control. But what they didn't see was how exhausted she was. LaToya struggled with severe depression and anxiety, but she had learned to hide it well. She never let herself break down in front of others. For months, she'd been researching suicide methods online. She told herself she'd never actually do it, but deep down she wasn't so sure. One night, a friend jokingly asked, "You're always so calm. Do you ever get stressed?" LaToya forced a smile and said, "I guess I just handle it well." 2 days later, she attempted suicide. Warning signs often missed in people like LaToya. Unlike Jason, who explicitly verbalized distress, LaToya hid her pain. This is common among individuals with high-functioning depression, where they appear fine on the surface but are deeply struggling. They may secretly engage in self-harm or make passive suicidal statements like, "I wonder if anyone would miss me if I disappeared." They have internalized stigma. They don't believe they deserve help. Assessing LaToya's risk. Risk factor, LaToya's case. Passive suicidal thoughts. Yes, frequent thoughts, but told herself she wouldn't act on them. Social withdrawal. No, she remained highly social, masking her pain. Internalized pressure to appear strong. Yes, she didn't want to be seen as weak. LaToya never spoke up, making her a case of silent suicidality. Intervention for people who hide their suicidality includes building trust, challenging cognitive distortions, teaching coping strategies for distress, and removing barriers to seeking help. Final thoughts. The role of society in suicide prevention. Suicide isn't just an individual problem, it's a public health issue. Preventing suicide requires action from communities, families, workplaces, and governments. Key takeaways. Suicide risk is preventable if warning signs are recognized early. Crisis intervention works. Safety planning, emergency care, and therapy can save lives. We must challenge stigma. Talking about suicide openly helps people seek support. Resources and support.